Hello, everyone. I'm Madeline Milka, President and CEO of APAICS, the Asian Pacific American Institute for Congressional Studies, and I'm thrilled to welcome you to the 2024 APAICS Health Summit. I'd like to thank our summit partners, Amgen, Cencora, Biogen, Bristol-Myers Squibb, Pharma, Walgreens, Planned Parenthood, Catholic Health Association of the United States, GlaxoSmithKline, and Otsuka, as well as all of our special guest speakers, panelists, and moderators. Your support enables APAICS to fulfill its mission of promoting Asian American, Native Hawaiian, and Pacific Islander participation and representation at all levels of the political process, from community service to elected office. The Health Summit brings together frontline workers, community and corporate leaders, subject matter experts, and elected officials for bipartisan policy discussions that affect our communities and the nation at large. Today, we'll hear discussions on the social determinants of health, challenges and opportunities with health policy and accessibility, and what our partners are doing to adapt to changing conditions in the healthcare industry to better serve the AA and NHPI community. It is my pleasure to introduce KPAC Executive Member Congressman Ami Bera. Representing California's 7th Congressional District, Congressman Bera brings a wealth of experience in healthcare as a former physician and a deep-rooted belief in evidence-based policymaking. Congressman Bera currently serves as co-chair of the KPAC Healthcare Task Force, where he aims to tackle health disparities, improve access to healthcare, and support culturally and linguistically competent outreach through legislation and education. Let's welcome Congressman Bera to the APAICS Health Summit.
Hi, I'm Congressman Ami Bera, Dr. Ami Bera, and I'm one of the KPAC co-chairs for the Healthcare Task Force. I'm thankful that APAICS is having this Healthcare Summit. It provides an opportunity for us to look at the real unique healthcare aspects that impact the Asian American community. It is fine for us to look at health from a macro level, but there are unique aspects that we have to disaggregate data and focus in on, particular areas of the Asian community. Because again, we're not a homogeneous community. If you're Filipino American or Indian American or Chinese American, we should look at those individual communities as well and how disease impacts all of us. So again, thank you to APAICS for hosting this summit, for the advocacy work that you do, and again, have a great summit. Be well and be kind to one another.
I would now like to give a warm welcome to Congresswoman Pramila Jayapal to introduce our first panel. Congresswoman Jayapal is serving her 4th term in Congress representing Washington's 7th Congressional District. She is the first South Asian American woman elected to the United States House of Representatives and one of only 24 naturalized citizens currently serving in the United States Congress. Prior to her work in elected office, Congresswoman Jayapal spent almost a decade working on global health and development for the international nonprofit organization Program for Appropriate Technology in Health. Let's give her a warm welcome.
I'm Congresswoman Pramila Jayapal, and I'm honored to represent Washington's 7th Congressional District in the House of Representatives, where I also serve as chair of the Congressional Progressive Caucus. Thank you all so much for inviting me to share a few words today about AA-NHPI health and what we can do to close the gaps in the health research and health care sectors. When I became the first South Asian American woman ever elected to the House of Representatives, I knew that I had the responsibility and the opportunity of bringing the perspectives and experiences of my community with me to Congress to try and make a change. Those perspectives and experiences led me to introducing the South Asian Heart Health Awareness and Research Act, the first legislation ever to both raise awareness about the alarming rate of heart disease for South Asian Americans in the United States and also to put resources to reversing this trend, research that will help South Asians and all Americans. No community should face disproportionate health outcomes because of a lack of research, understanding, or awareness. There are steps that we can take to right these wrongs and to ensure that everyone has a fair shot at living a happy and healthy life. As I call for in my South Asian Heart Health Bill, we need to put more effort toward data disaggregation in medical research. My legislation would provide grants and resources for data on AA-NHPIs to be broken down into further subgroups rather than just one broad AA-NHPI group. Not every person from the AA-NHPI community is the same, and not every one of us has the same health needs. Without disaggregation, critical research findings are often hidden in larger data trends, and that hampers drug development and treatment. We also need to remove barriers and build trust to promote AA-NHPI people and other people of color participating in our clinical trials. Our health research system has to take more care to focus on these details so that we can give all members of the AA-NHPI community better tools to manage their health and achieve positive outcomes. More broadly, we all need to continue the fight for universal health care where the focus is on people and not profits, where everyone can get the care they need whenever and wherever they need it without incurring debt, where our grandmas and our aunties don't have to cut their prescription pills in half at the dining room table because they simply can't afford the high prices of necessary medications in this country. What we know is that lack of access to healthcare, high prices, and medical debt disproportionately affect communities of color, including AA-NHPI communities. Our work together to ensure that everybody is in and nobody is out is so important. So thank you all for taking part in this discussion today. Having these conversations is really important in ensuring that our advocacy efforts are focused where they can have the greatest impact. And as you all keep doing this vital work, I will be right alongside you in Congress, working to pass legislation, to secure funding, and to lift up AA-NHPI voices fighting health disparities across America.
Thank you, Congresswoman Jayapal, for your continued efforts to advance the needs of the AA and NHPI community in healthcare. And as the Congresswoman mentioned, our first panel of the APAICS Health Summit is Closing Gaps, Advancing DEI in Health Research. As the healthcare field advances, it is crucial to spotlight the disparities and research gaps affecting communities of color. Beyond funding, major hurdles occur to engage AA and NHPI individuals in clinical research, including mistrust, lack of information, and poor representation across the diaspora. This panel will explore the multifaceted challenges in health research, including diversity within clinical trials, disaggregated data of trial results, and the need for additional investment in rare diseases that disproportionately impact AA and NHPI populations. I'd like to introduce the panel moderator, Iyanrick John. Iyanrick is Vice President of External Affairs at ChangeLab Solutions. Prior to joining ChangeLab Solutions, he served as a senior policy strategist for the Asian and Pacific Islander American Health Forum and helped to guide the intermediate and long-term policy and program strategy for the organization. He also assisted with the Health Forum's policy and advocacy efforts to expand access to healthcare, improve healthcare quality, and further the collection and reporting of data for communities in order to address health inequities. Please give a warm welcome to our moderator and our group of panelists.
Thanks for that introduction, Madeline. I'm very excited to moderate this discussion today. Let me share a little bit about my organization, ChangeLab Solutions, first. Our organization focuses on using the tools of law and policy to undo the fundamental drivers of inequity and change systems. We address these drivers by providing legal analysis, technical assistance, and guidance on the policymaking process, and share resources including model policies, toolkits, and other products on health issues in areas such as planning and housing, food systems, and investments in family supportive services. We have an interdisciplinary team of attorneys, planners, policy analysts, and other public health professionals, about 60 or so staff right now spread all over the US, who work with community organizations, local and state governments, researchers, health systems, and other individuals and entities to design and implement equitable and practical policy solutions to complex health challenges. And we believe these complex problems are best solved through partnerships across multiple disciplines and sectors, like some of the partnerships you'll hear about today, to maximize collective resources and align actions to advance health equity. And if you're interested in learning more about our work, please check out our website at changelabsolutions.org. So now let's turn to our panel for today. I'm excited to be here and thank you all for joining us today. I'm going to briefly just give an introduction of each of our panelists, and then we'll jump into the questions for today. So first, we have Dr. Maile Tauali, Collaborative Investigator at Hawaii Permanente Medical Group, Jackie Leung, Executive Director of the Micronesian Islander Community, Dr. Viet Nguyen, Medical Director of Research and Development at Biogen, and Ramita Tandon, Chief Clinical Trials Officer at Walgreens. So thank you all for being here today for this discussion. And the first thing I want you to just kind of talk about is just to share a little bit about your work, your organization, and any specific work you're doing related to racial and ethnic inequities in health research. And I'll go ahead and start with Ramita.
Great. Thanks, Ian. Great to be here today. As Ian mentioned, I am the Chief Clinical Trials Officer at Walgreens. And, Walgreens has been on this, tremendous journey as we are driving more healthcare services within the communities that we serve. For those that are not familiar, we have 9,000 stores and pharmacies across the nation. We serve roughly over 110 million lives that visit our stores and pharmacies on a regular basis. And certainly, during the pandemic, we learned a lot, right? When everything was shut down, the retail pharmacies were open, and it allowed for communities of color, communities that were underserved, to come into their local Walgreens, to be educated, engaged, and empowered, and learn more about the vaccination programs to get shots in the arms. And so my role at Walgreens is I've joined the organization as I've built out a clinical research enterprise, one that is patient-centric, one that tackles two key areas. Number one, the issue around representation. We know that less than 5% of this nation participates in clinical research, and of those that participate, 75% are Caucasian. Number two, accessibility. Obviously, with the many communities that are out there today across the nation, not everybody has the ability to participate in clinical research. Historically, and today, our clinical research enterprise, across the industry has enabled urban, white, affluent neighborhoods. And as a result, we've not been able to bring a representative patient population to clinical research. So at Walgreens, our goal is to make sure we're tackling both representation as well as accessibility.
Great, thank you, Ramita. I'll turn it over to Viet next.
Hi, thanks, Iyanrick. I'm Viet Nguyen, Medical Director in Research and Development at Biogen. We were also struggling with a lot of the same challenges of how to create these clinical trials that are representative of the world's population, not just the ones that have access to these major specialty or academic centers where clinical trials tend to occur. I led the creation of a Biogen toolkit for diverse representation in clinical research. We're currently implementing that through each of our different drug development programs. It's based on incorporating guidance from the Multi-Regional Clinical Trials Center of Harvard University and Brigham and Women's Hospital in Boston. Our drug development teams, we condensed this guidance from that resource and sort of thought about how it would implement in different R&D processes within Biogen. So our drug development teams can use this toolkit as like a checklist of activities with internal collaborators and external experts to engage people in what it takes to make the research inclusive, including patient and community engagement, epidemiologic research, clinical trial design and the implementation of those trials, and data analysis once the data comes in. This is particularly important for our company because we work in a lot of rare genetic diseases where if you have a rare genetic disease and you're in an underrepresented or rural population, it can be very difficult to access care at these specialty centers. And we know this because those patients often experience longer delays to diagnosis, and they have decreased exposure to clinical research opportunities in general. And even when they do enroll, they have a higher burden of study participation. So we're looking at the systemic barriers to what it would take to get greater participation. For the ANHPI community in particular, we will look at how the clinical trials can include, so the current apparatus in clinical trials is really emphasized on speed, how quickly can you enroll people, and then cost, like how can you get coordinators and translators and translation services to make these materials available to all these populations. And then also, companies tend to concentrate the clinical trial activities at major academic centers and specialty centers instead of using these touch points out in the community based upon just the way things have always been done or the way that things are easiest done. And so building processes into our research to account for that and say, no, it might be okay to enroll a little slower and to spend a little extra in order to build out a better data set, a more inclusive data set, so that when you do your analysis, it becomes more meaningful, and to allow for that within our internal processes. But then also there's hesitation in a lot of these communities to participate in scientific research because, well, they haven't done it before. And can you really trust the doctor that you don't normally follow with, the doctor that's all the way at that center? And I think a lot of that comes with communications, especially in rare disease. You know, there's ways to connect that community, and they're already connecting themselves through things like Facebook, and to get into part of that discussion, saying, "Hey, these are ways in which we can bring new treatments for these diseases that often don't have any disease modifying treatments today."
Great, thank you. Thanks, Viet. Thanks for sharing that perspective from your work at Biogen. Let me turn it to Maile and share a little bit about your experiences and work at the Hawaii Permanente Medical Group.
Sure. Thank you so much, Ian. I think it's amazing to be with a group of individuals who are actually doing research, not in this sort of standard, everyone thinks universities is where all research occurs. I like you mentioned, I'm a collaborative investigator for Hawaii Permanente Medical Group, which is part of Kaiser Permanente. We're the provider and physician side of the house. And as an organization that prides itself in really serving underserved communities throughout the country, we really have invested a lot of energy into building research into the way that we practice healthcare. I always try to explain to folks who are funding a lot of big research that having research partners who actually have patients who can make a difference immediately and pivot on the way that we actually implement change as a result of doing research that is directed and needed by our communities. The research that we get to do is based on how to make healthcare better, how to make medications more effective, how to get patients to feel comfortable in the healthcare setting, and we get to change the way and implement that research immediately in our healthcare system. So it's just really, I think we all as a country need to think a little bit differently about where is the best place to conduct research. And places like ours, where we have those special relationships with communities, because we're daily trying to ensure people have access to medication and research, and healthcare and providers that actually are family members. It's really special to be with a group like this. My job is really, as I'm an Indigenous scientist, so I stand in both spaces. I am a member of my community, but I'm also a researcher, and that's by design. I was a community member long before I was a researcher, and I got the degrees so that I could serve my community and be able to address the health concerns that my community is raising and be a friendly face and someone who could be trusted in the way that we do research. So one of the things that I think I'm able to do is help my community understand how research can be beneficial, as well as help the organizations and the research community be very respectful, patient, and understanding of what the community's needs are, and that their needs come long before what is currently funded by NIH or whoever. It's what the community wants paid attention to, and that's really important. So it's really great to be with such an amazing group of individuals who are thinking about how to get this care and the work that research can advance immediately into the hands of people who need it. So thank you, everyone. It's really great to be here.
Thank you, Maile. Thank you for sharing that. I think you raised a really important point, the importance of trust and in research. So thank you for bringing that up. I'm going to turn it to Jackie also. And Jackie, just share a little bit about your work as the director of the Micronesian Islander community.
Thank you, Ian. And thank you everyone else for sharing your perspectives and backgrounds in terms of how we're trying to increase representation as well as participation of our communities. I mean, we need to see that, and that allows us to be able to gather important information so that we would be able to better serve our community. And I kind of want to touch a little bit on this idea of trust. I mean, for me, I run a nonprofit, and we have done some research on our own as well as research with both institutes and with universities. But one of the biggest things that we've always pushed for was part of the data ownership, and then essentially the ability for our organization to be able to have access to that data as well as have a say in how that data is utilized. And that's another key part when we're talking about trust is, yes, we're going into your community, and yes, we will be collecting this data, but what are you going to do with this data, and how are we going to then also ensure that what is being collected and what is being informed accurately reflects the ongoing health issues or ongoing needs of the community. So we focus a lot more on the community-based research process, but we also, one of the things that we've done, like especially over the past few years with any kind of partnerships that we do, is that we have specific contracts that state, yes, we will work with you and we will partner with you, but the expectation as well is that any data that's collected, we have equal access or ownership to it. And in terms of any kind of publications, we also have a say in what those publications look like, as well as potential for authorship. And by having that combination piece where we have the importance of, yes, we now have participation, we have this trust buildup, but now we also have access to this data where we also would be able to explain what it is, where you're not just coming in and collecting data from us, but you're working with us. And essentially there's this one saying that said, nothing without us, nothing on us without us. And so that to us is part of what our idea is when we are working and collaborating in any areas of research and data analysis.
Great, thank you. Thank you so much, Jackie, for bringing that perspective. I think several of you have touched on some of these barriers and challenges that you see in health research. But if you could share a little bit more about some of the barriers and challenges specifically impacting AA and NHPI communities, and then maybe talk a little bit more about what your organization is doing specifically to address these barriers, specifically for AA and NHPI communities. Maybe I'll pass it to Ramita to take that one first.
Sure. I think everybody touched on some key themes that I think we can continue to carry forward. The notion of trust for us is absolutely critical. We've been in the communities, well over 100 years, and we know that many of our communities, particularly AAPI communities, have come into their local pharmacies, have the conversations. But more importantly, as within this clinical research enterprise, we've opened up our locations to become welcome entry points. We have people that are staffed that look like them in the communities, that are able to, translate information in a way that they can understand it. We know that many communities across our nation have digital literacy disparities, broadband access issues, you name it. This is the real world that, faces many of our communities today. So a couple things that we've done, certainly as we think about our physical footprint, we have built out our clinical research sites within our pharmacies where we have private health rooms that allows our patients to be able to come in to, first and foremost, be educated and informed of what a clinical trial is, down to the very basics, so they can feel comfortable and ask the right questions, and then feel empowered to make the decision to participate, number one. Number two, where there's an opportunity as we conduct clinical trials within these clinical research centers at Walgreens, we're able to provide low complex services. So screening, diagnostic, and blood draws. The idea is that for those that are unable to continue to make the clinical research centers or academical centers or their physician sites, they're able to come to the designated local Walgreens to be able to have their follow-up visits done. Again, we want to make sure that we can enable better accessibility and make it easy and not burdensome for the patients to participate. And then thirdly, it's really around just raising awareness. So many of our locations today, if you're out there to go pick up a prescription and you're flagged for a particular clinical trial that we're running at Walgreens for one of our partners, it'll get flagged in the system, and our pharmacists will be able to see that within the system and be able to make that notation to that patient and let them know that they're eligible for a particular clinical trial. And if they're not willing to talk about it, which absolutely makes sense because oftentimes people come in, they're quite busy, there's two ways. A lot of materials are put into the script bags. There's QR codes that, refer them to a call center that allows them to be able to talk to folks to be able to, get them to understand what a clinical trial is and see if they'd be willing to participate. So we've certainly unlocked our stores and pharmacies as the welcome entry point to be able to, have our patients to be able to come in and learn and to be able to have some of the clinical trial services done on site.
Great, thank you, Ramita. I think that point you made about access is so important. Making it easy for patients to participate is really important. And Viet, let me turn to you. And you talked a little bit about some of the work around your rare genetic diseases. And maybe you can say a little bit more about some of the work that you're doing to address some of the barriers and challenges. You mentioned some earlier, but some of the work that you're doing to address barriers and challenges specifically for A and NHPI communities.
Sure. So I think a bulk of the efforts are ways to decentralize the trial activities. So, you can still have a major academic center or specialist running it, but what are some other ways that we can send these touch points further out into the communities, further away from these centers? I think sites in the communities like Walgreens or local clinics are an important part of that. But we've really been leaning into these home, trying to do clinical trial activities at home, which I think digital technologies enable some of that. We employed some home health services, these contract home health services to come to the home and do some of these activities, including lab draws or diagnostic studies. There are clinical trial activities that we've digitized onto things like tablets or smartphones or web interfaces for patients or family members to enter their data in and collect that way. We've done some clinical trial visits activities through telemedicine visits, like video conferencing. There are some things you can do in those settings. There are other things that have been very difficult to implement. But trying to make these trials as decentralized as possible. We recently completed our first fully remote study. So that was a non-drug study in a rare genetic disease. It was a small study, so fewer than 50 people. We had an islander that was able to enroll in the study specifically because it was fully remote. They would not have been able to fly out to the mainland to go to clinical trial visits every few months. So we were able to bring them in because of that and keep them in for the whole study. So we're very proud of that. There are different levels of technological sophistication in all these in different populations, and we had to have a system in place to give people assistance with the tablet devices, with some of the home health equipment to make sure that things were working, that they stayed working, that they could troubleshoot them. We had one participant that had connectivity issues. They essentially, lost their home internet, and so we had to come up with a solution for them to keep them connected to the clinical trial activities. So these are all like these real world challenges that drug companies have not really had to deal with historically. But if you want to make it happen, you find ways to deal with it, and you keep these people connected in. So I'm very proud of our ability to do that for this first fully remote study, and our plan is to try to roll this out to more of the programs, especially these rare genetic programs throughout our pipeline.
Great, thank you, Viet. Let me turn to Maile and ask if you can talk a little bit about some more around research outside of clinical trials that might be helpful to talk about in your work.
Sure, thanks. I think what was just discussed is really important. Clinical trials and getting medications that are actually effective in our unique communities is really important. So I really appreciate that discussion. to expand on it, there's a lot of research that is happening that isn't in the clinical trial or medication space. And we're still doing research on just how do we make systems work better, which we do talk to patients, and some of it is even qualitative, where you're just asking people, like, what do you want? How do you want it to look? What can we do better? And so a lot of that research, it's about engaging patients. It's about engaging community to want to participate, to share their story, to share their experiences. And like what we talked about before and what Jackie mentioned, trust is really important in order to have folks want to spend their time to share and give their experiences with the hope and intention that we're going to pivot and change and do something about that. So I think that there's a lot of research and getting our community to want to participate or feel that there's value in it is really important. Other aspects of research that I think we aren't participating in as much as we need to be, and that's in biorepositories. And it's because of the distrust, and it's because of the way that biorepositories have been, or research tissue gathering for research in the future, it's really been handled in ways that has not made our communities feel safe, or it's just been blatant abuse. And so really there's a lot of work that's happening to help folks who oversee research in institutional review boards, human subjects folks, to try to explain what is group harm and how our communities are actually harmed, not on a individual personal basis, but how stigma and how when things get published and communities' names and where they're from and who they are gets put into the press and taken out of context, and that kind of stuff. We as a community need to help folks who are doing that kind of research or overseeing that research or even funding that research learn how to do it respectfully. So really thinking about partners to help research be done in an ethical and respectful way so that people feel safe coming to the table.
Yeah, thank you so much, Maile. Very, very important points that you made there about the biorepository piece. Jackie, I'll turn to you and see what else, if there's anything else that you'd like to add.
Yes, thank you. I want to touch upon a few of the things that Dr. Maile had focused on specifically, going back to that sense of community, that sense of trust in that space. I mean, people from our community, especially our Micronesian community, they're already a minority within a larger minority group. Got Micronesians who are lumped in together with Pacific Islanders, who then get lumped in within the Asian American, Native Hawaiian, Pacific Islander narrative. So that key piece has always been like that sense of invisibility. So the need to feel seen and the need to be seen, like those are some important processes and steps in being able to ensure that we have more representation and accurate participation. Another key piece that we've also dealt with are, do we have actually people who are properly trained for language support? Interpreters, for example, are the interpreters that we're utilizing people from the community who actually speak the language? And how about the translation of materials? Are the materials that are being translated accurately, but most of all, can people understand it? Some examples I could give you specifically is like my nonprofit once had a translation we happened to see it on social media, and it was actually for a research project. And I sent it to several of my staff and I asked them to look at it. And it was translated in six of the Micronesian language, specifically people from the Kofa nations. So that was Chukis, Marshallese, Palauan, Pohnpeian, Yapis, and Kosraean. I had 4 of those languages looked at. And of those 4 languages, 3 of them were actually pretty bad. The one that was the most offensive was actually in Palauan, where a part of it looked like it was in Palauan. Then some of it looked like it was either in French or Spanish, and the rest of it was gibberish. So we don't know if there was some sort of Google Translate that took place, but something happened during that translation process that this was already published and out for community to be responding to. So if we are not utilizing the properly trained interpreters and even the translators who know what they're doing, what kind of disservice are we incorporating in-house, as well as trying to do better within the community? So that also means that we have to have the ability to be flexible and being willing to pivot, and ensuring that who we're utilizing for services are actually individuals from our community who know what they're doing.
Thank you, Jackie. Really, really important points that you made there. I'll see if Viet or Ramita, if there's anything else that you want to add with regard to what Maile and Jackie said.
Yeah, from our perspective, I echo the themes that I heard around community engagement and activation. It's actually it's a critical step for us at Walgreens as we think about the workflow, because, just because you send out some kind of outreach to members of the community, particularly those that have mistrust, fear, or lack of awareness, or never been invited to a clinical trial, that's not going to automatically mean they're going to just want to say, yes, I'm going to participate. So that engagement and activation is an absolutely critical component for us and what we're seeing as well within the Walgreens ecosystem, so that we create that surround sound as we try to build the right highway, to bring trials closer to where the patients are. And I think I can't stress upon enough is that work needs to be done. Not every organization, I think to what Viet said earlier, because traditionally clinical trials are meant to let's enroll, let's get it done faster, let's not take the time. But if we truly want to go after and make sure this is community-centered research and we're going to get representation, we have to do the hard work. And we've got to acknowledge those barriers, and we've got to make sure we've got the right infrastructure, the right resources, the right tactics and tools that we're deploying within these communities that enable the right highway so we can bring trials closer to where the patients are.
I would agree with that. There are ways to make these systems work within any system. I mean, in the clinical trial space, drug companies it's a very highly regulated space. And so we can't just throw a material into Google Translate and then post it back on a website. That would be against protocol. But there are a number of protocols we have that I think would help get these things out into the community better. So, for example, in the toolkit that I built with my team here, there's a process that we can follow where you have representatives within the community. You outsource. We don't have all of these people within Biogen to do translations, so you hire a translation service to do them, and then you bring the materials back to that community and see, hey, can you look at this and make sure it makes sense? And so that's like a standard operating process that you build out that's included in our toolkit for diverse representation in clinical research. So if people follow that, then hopefully they won't run into some of those awkward situations that Jackie has seen.
Great.
And I would just add, Viet,
Yeah,
just
go ahead.
one thing, the other piece of it is that bi-directional feedback, because as we start to, at least what we're seeing at Walgreens, as we start to put more into the communities, we're also listening and iterating, right? Because it's not a one-size-fits-all model in many of the communities that we serve at Walgreens, but for us, it's about just making sure we're listening, and it's bi-directional. So as we push out more information, we're going to listen, and then we're going to modify so that it actually does enable them to make it easier for them to participate in clinical research.
Great, thank you. Thanks, Ramita. As we're coming towards the end of our panel, I think, there's several themes that have come out so far. We've talked about the need for communities to see value, participation in research, kind of community access as being important, the need for communities to be seen and respected, and trust. I think, in this audience, we probably have a lot of people that are at government agencies. We have policymakers, probably some funders. What are their roles? What roles can these individuals play in alleviating some of the challenges that we've talked about on this panel today? I'll let anyone jump in there. Any thoughts you have?
I can jump in. I think funders are probably the most important as far as being able to implement change, because funders dictate how those who are applying for funding to do research actually have to respond. So I think it's really important for funding agencies to think about what they ask for by communities and organizations and researchers, and things that should be constantly incorporated into the way that research is done is education to our communities and education for those who are serving our communities. I mean, research is great, but if it's not reaching the people that it's intended to, it's really it falls on mute ears, and our communities are invisible. So if funding agencies can make sure that research includes aspects of education, our communities, I think, don't necessarily understand the connection between how research relates to improved care, and that we're important in part of that because of our unique issues in our communities, our unique genetic makeup. And as medicine moves more and more into the pharmacogenetics, toxicogenomics area, we need to have our people participating in the research so that the medications and the treatments and the things that are coming out are also going to benefit our communities who have some of the worst health disparities in the nation. The other aspect of it, I think, that needs to tie into it, and this is the long-term investment, is we need to fund and we need to support researchers who are reflective of the communities that they serve. Research that is led by Indigenous communities, by minority communities, by communities who are affected by the illnesses that we are facing, because we have these unique things in that we are members of these communities and we are also leaders in these communities. And our communities expect us to be there, present, and also accountable. We don't ever have the ability to leave or walk away. So our accountability and our ability to serve is genuine and built into the way that we live. If I ever made a mistake, it would affect my children and my ancestors. So we behave very respectfully and we're held accountable. And I think that's really important. There's no helicopter research that occurs in our communities when the researchers themselves are reflective of the communities who are needing access.
And I think, from our perspective, I would echo the notion around education. When we're having the conversations, we're equating to the research as a care option, right? Because many people still view clinical trials as this scary, being a guinea pig type of scenario for them. But we truly see this as an extension of their healthcare journey and a true care option, particularly if they've been on a number of other treatments that have not been working. So again, the notion of just raising the awareness and making sure education, as Molly just said, is a key component of the funding exercise and the design. But the second piece is around continuing to push non-traditional models, mechanisms, and settings of care, right? Because as we've seen historically and today, clinical research has been done in academic centers, has been done in care settings that, again, has not been enabling, many of our communities across the nation. So COVID-19, the pandemic certainly put a spotlight on looking at non-traditional partnerships, mechanisms to get research, to carry forward. My hope is that these agencies and other funding partners continue to go down this path of embracing non-traditional settings of care, tools and mechanisms, things that Viet also talked about as we look to bring trials into these communities and make it more accessible for them to participate.
If there's any regulators in the audience, I mean, there's, the FDA has had a draft guidance out on diversity plans for trials. So, drug companies are, in order to get a drug approved, it needs to go through a regulatory agency and they have to approve it. And now that regulatory agency in the United States, at least, is asking for these diversity plans for anything that's going to be end of phase 2 or beyond. So things that are going to be, close enough to the clinic where you really need to start thinking about these things. So there's an accountability aspect for drug development companies to this as well. The flip side to that is once you start gathering data outside of these academic specialty centers that are used to doing clinical trials, there's a larger variety in the capabilities of a lot of these more community-based centers. And so it'll take some creativity and I think some leniency and a lot of dialogue to make sure that we're able to accomplish about the same amounts of science, of answering the questions you want to the level of rigor that we want, without having to require everything to be done in a clinical trial center that's able to check all of the boxes needed to pass regulatory muster. So I think that's an evolving space. I think having community involvement in all of these groups, including ANHPI, is going to be super important in this because ultimately we all want the same things. We all want to bring new treatments to people that don't have treatments for their good enough treatments for their diseases. And we want these drugs to work in everybody, and we want them to be safe in everybody.
Let me add on a little bit too of an example of like how we could continue to engage community as part of the research process. So Micronesian Islander community was part of a larger research project called the Pacific Islander Data Modernization. This project took place specifically in Oregon, and what the Pacific Islander Data Modernization Project did was expand on data collection efforts that were within the Pacific Islanders community in Oregon. It started off specifically in Multnomah County as part of a data project, and then community counts. And then this specific data project actually was in November of 2018. And there were 5 main objectives behind it. It was understanding our traditions, understanding our health, increasing the value and importance of Pacific Islander data as long as it was accurately collected, building capacity and strengthening partnerships. And what ended up resulting is the development of something called the Pacific Islander Health, Equity, and Liberation, or PI-HEAL assessment. And this was developed as a way to tell the story of Pacific Islander health and healing. And this specifically actually drew inspiration from the Prevention Institute's Thrive, which was a tool that's used for health and resilience in vulnerable environments. And so the main core areas that we focused on for this assessment was on people, place, opportunity, and healing. And it was a combination accumulated from both data collection that we had from surveys that were collected, as well as interviews that were conducted. So these are some potential pathways that we could continue to work forward in terms of how we might be able to engage research with community.
Great. Thank you all. This has been a really helpful discussion. I've enjoyed hearing all of your perspectives and your thoughts, and really the importance of how to have our communities more involved in research. What are some of the ways that we can think about that in non-traditional ways when we think about clinical research? And thank you all for your efforts in the work that you're doing in your different spaces. As we close out the panel, I just want to see if there's any last words that any of you want to share, any final thoughts as we get ready to wrap up here, but really appreciate your contributions. Anyone have any final thoughts that you want to share?
It's been really great to work in this space with a lot of enthusiastic and committed individuals that are all working towards the same goal. Nobody knows all the right answers, but it's great to have people that are interested in seeking out what those answers would be.
And Jackie made a great statement earlier, nothing about us without us. I'll let to add on to that with nothing about us without us leading. I think leading as members of the community, leading as researchers, leading as organizations who have invested and really care about the outcomes of community having access.
And I would just add, I think it's exciting to see the commitment and the passion folks are having. My ask is, as we continue to see good outcomes, we share those collective stories, case studies, and proof points that it's working, because the more body of evidence that we can create with what we're all doing and starting to maybe drive influence, whether it's at the regulatory side, whether it's with funders, everybody needs that the body of evidence is working. So my hope is that we continue to push all the case studies and the proof points that what we're all doing is working. So thank you.
So the thing I'd just like to add to is just kind of reiteration of what everyone else is focused on. Like, we need that data disaggregation piece that actually showcases the differences that are taking place within each of our diverse communities. But we also need the recognition of and funding to actually be able to do this, and recognizing that, yes, you got money and you might have it for these specific projects and needs, but is that something that our community is focused on or needs right now? Is it something that there's some flexibility with the funding where we would actually be able to develop together research questions, processes, developments. I mean, all those key pieces, it's been shown that it can work. So why don't we move forward with it and ensure that we actually have the accurate representation and the saturation that we need from all the different groups to ensure that we have the representation that we need and participation that we need within research.
Thank you, Jackie, and thank you all. I know you're all busy. Thank you, Maile, Viet, Ramita, Jackie. Thank you all for being here today, sharing your thoughts and your ideas in this important discussion. I hope this has been helpful for everyone that's watched this discussion today, and I hope it continues more thoughts and ideas on how we can think about the ideas that were brought up today. So thank you all for joining us, and hope you all have a good rest of your day.